Hi, everybody. So I'm going to start with genitourinary surgery. So now you know how to pronounce it correctly, but this is GU surgery. We'll be doing a lot of cystoscopy, but we'll also be talking about open belly type of surgeries too. So GU is very different. So I will go ahead and share my screen so that you can follow along with me with my slideshow. So this is chapter 20, genitourinary surgery. Okay, so it starts on page 801. This is a good example of a you're responsible for everything in your chapter. That's because I won't go over each individual surgery. So as always, you're responsible for everything that's in your book, but of course the lecture is to help you figure out what to pay attention to as you study and to help you better understand some of these surgeries with my own personal experiences and some of the pictures that I share. So on page 801, the introduction gives you a good outlook into everything that you're going to see in GU surgery. Of course, you should know all of your terms in purple. So as you read through, make sure you're hitting the key terms, but it's talking about all of your diagnostic stuff in the beginning as usual. You'll notice it's a lot shorter. That's because a lot of these testings are urinalysis. So I want you to focus on hematology findings. So right there, it talks about prostate-specific antigen test. So on this one, I want you to know that it's useful in determining cancer of the prostate. So an elevated PSA does not automatically indicate that there is cancer, but we should follow up with a prostate biopsy. So because that's one of the cases that you will be focusing on in this chapter, you need to know the specific test to do biopsies for prostate cancer. So again, the blood value test is the PSA or prostate specific antigen test. So if they see elevated PSA, elevated levels, they will follow it up with a prostate biopsy. So after that one, like I said, urinalysis is a great way to determine whether you have some of these pathologies where you'll need some sort of genitourinary surgery. After that, page 802 and 803, your green boxes. Yes, you should read through these, go through some of the terms, and hopefully a lot of these terms, especially your hematology findings, those terms should be familiar. Some of the ranges, you should have an idea whether it's a big or small number. I do not want you to spend all your time memorizing these numbers, though. So spend more time on the surgeries, but again, read through these important charts, especially your hematology findings, should be familiar words as you go through it. So let's move on, page 803, radiologic findings. So on this one, this is a good reminder that in GU surgery, you will have x-ray in the room quite often. This is a good way for us to look at the kidneys, look at the ureters, look at even other structures inside the body. But a lot of the times when we're looking for kidney stones, we will be using x-ray. So make sure you pay attention to all your radiologic findings, but no, we'll use x-ray in the OR. And then read down another term in purple, IVU. So intravenous urogram. You've already learned this term, so it's reminding you to pay attention to this part and know what they're going to use it for. So intravenous urogram, IVU, you should know the previous name too, IVP. Enhancement of the KUV that involves injection of contrast media into the patient's vein. So this is a little bit different. The radiopaque material is filtered through the kidney and then excreted out of the body. So go over IVU on your radiological findings. After that, let's look at page 804. So on page 804, you'll see some of the different ways that they are going to get their diagnoses. So you've got biopsy and endoscopy, and I'll go over both of those in the cases. So let's focus on instruments. Okay, so instrumentation. This is a good idea of what your instrumentation is going to look like very often in cystoscopy. So With genitourinary surgery, you have open belly working on the kidney, working on genitals, different exterior portions of the body. But then a lot of your surgeries are this, putting a scope and looking at the bladder. So your instrumentation is very different, but some of the features should be familiar for you. So example, your camera, your light cord, that should be familiar with you. The lens, we usually call that the endoscope, but still you should be familiar with these objects used on instrumentation. So after that, go to where it says general on page 804. So it talks about the different open belly trays, not pictured here on this slide. So long instrument trays to get down to the bladder, self-retaining abdominal retractors, handheld retractors, and then look at all your bullet points for your vascular stuff. So mixture right angles, that gets around ureters, vessels, anything else you need. Potts scissors are for vessels. Vascular instruments, of course, for vessels. Hemoclip appliers to clip vessels. Bladder and prostate retractors. So what I'm getting at is you will need lots of things to help clip and stop bleeding. So lots of silk suture, lots of hemoclips on these cases. Okay, after that, you'll see for the kidney, they have specific instruments. And then some of these cases, kidney especially, you'll be so far lateral that we'll actually be working on the ribs. So there'll be a small rib resection. So that's why some of those rib instruments are placed there. I will skip over that equipment for a little while and keep looking at our instruments. On page 805, you need to be familiar with all of your GU instruments, but pay special attention to letter A and B. So you've got your Herrick kidney clamp. This is great for transplanting kidneys or nephrectomies. And then the Welltham-Cullen pedicle clamp, better known as pedicle clamp. I've never heard anybody use the specific name with that one. So just a pedicle clamp to clamp onto the pedicle when doing kidney transplants. Okay, after that, it switches from open belly to our more genitourinary and well-known instruments. So of course you'll need dilators. So Van Buren are the name of the dilators you need to know for males. So for male, again, they have it in female, but typically they're gonna have these on the table for male. So Van Buren urethral sounds or dilators as we've better known them. Of course, they will be all different size because people are all different sizes, but you want to dilate up. So smallest to largest and always have lubrication for your surgeon. Okay, after that, we can flip to page 806. So on page 806, we have a flexible cystoscope. So you can see the different abilities that this one has as you read through it. But what I want to point out is this is going to be sterilized in a different fashion. So you're not going to send this down to SPD the same way. You want to make sure to get instructions from your preceptor on how to send this flexible cystoscope down to SPD. Okay, look at page 807. So more often use the rigid endoscope. So you're going to want to know these pieces on this page and how to put it together. So rigid endoscopic instrumentation. So know some of the parts. So let's look at the sheath, the hollow stainless steel tube available in many different sizes. The part I want you to pay attention to, stopcocks affixed to either side. So take a look at your obturator. You can see the stopcocks on either side. So this is for your inflow and outflow of irrigation fluid. So that is why you see irrigation tubing up here. So it's kind of the same idea, camera, light cord, but instead of insufflation tubing, we are using irrigation tubing. Okay, so inflow and outflow irrigation. After that, look at your, it says obturator on page 807. Know which one is your obturator. Know that this fits inside the sheath to facilitate introduction into the urethra. The whole point is to not traumatize that urethra opening. It says the mucosal lining specifically, but you don't want to cause any damage. That's why we have obturators. After that, where it talks about your telescopic lens at the bottom of 807, know the degree they typically use. Now, we want to have retrograde viewing, so you should already know that term and where we're looking. Know that they're going to want 120-degree lens for that. Okay, so look at that figure 20-5 really well to help prepare you. Next, let's look at our resectoscope. So I want to point out that this goes over the cystoscope. It works with the cystoscope. So it's kind of like you're trading out a piece, but you're still using the same lens, the same scope. You just want to have the ability to resect some tissue, to take some pieces out. So that's why we're going to use our resectoscope. So you'll see it comes with a bipolar cord. It can also come with a regular monopolar cord, has continuous flow, and this is found in our TERP set many times. Sometimes the TERP tray isn't called a TERP tray, it just says resectoscope and has everything you need to do a TERP. So I will get into that in a little bit. So your TERP resectoscope on page 808, know what TURP stands for. I'll get into that later. Know that your resectoscope allows you to resect pieces of tissue instead of just looking like our previous cystoscope. And then look at the accessories. I want you to see it has electrosurgical unit with a grounding pad, cable, and assortment of tips. So lots of different tips for the surgeon to pick from, but you will have to have an electrosurgical unit for this one. That's the whole point of being able to resect. We need monopolar or bipolar to give us that ability to resect. Okay. After resectoscope, let's look at some of the equipment that's inside of the room. So on page 809, you will see a specialty cysto OR table. So notice it says OR table. We are bad about saying bed when it's actually called an OR table instead of a bed. Even though we know it's a bed, our patient's going to lay on it. I want you to recognize this and know it as it belongs in the cysto room. So you can tell by the ring that it has around, and it has a mesh bottom fluid drain pan. So find on page 809 at the top where it says mesh bottom fluid drain pan. That's what you need to pay attention to. So another name is a strainer or just screen pan. I've heard it called strainer many times. But this catches all that fluid, and then it has a drainage system in the room. So all that fluid can go straight down that drainage system. Now, it also is going to have enough room for the C-arm. Lots of cysto rooms just have a C-arm that kind of lives in the room because, again, we're going to be using a lot of x-ray on these cases. So C-arm, strainer bed attachment, drainage system in the room, so on the floor, usually you can just hook up to the floor and drain out, and then all your cystoscopy equipment available. So you can see that this bed is set up differently for cystoscopy. Okay, looking at your bullet points, you'll see advanced cysto rooms have x-rays. So that's a good reminder for your second bullet point to always be wearing lead aprons and thyroid shields. Your drainage system, like I pointed out, is a mesh drainage system. So you're going to add that word in at that bullet point. An adjustable stool, the surgeon will be sitting down just like most GYN vaginal procedures. You need to be close to where you're working, so you'll be sitting down. And after that, it talks about the more equipment in the room. So built-in video, illumination, electrosurgical equipment. I want you to really look at these pictures, especially the rigid tower, to see what this is going to look like in the room. All of these boxes have a purpose, and you need every one of them to start the case. If one of them is missing, you can't start the case. And they're looking to you, wondering why you didn't bring that item in the room. So camera system for the camera you have, light source for the light cord you have. You see both pieces right there, the scope and the light cord, and then this whole tower. So they make it easy for you at most hospitals. All your cystoscopy stuff is going to be on one tower. You just got to make sure the tower is in the cysto room. All right, so after that, it goes through some supplies. So read through all of the supplies. Know that lubricant you're going to hear over and over again, so you know it's very important and you have to have it. We can really cause damage to our patients if we don't use lubricant, especially on the urethra. So You want to have extra available all the time. But read through all of these supplies. Let's stop at alternate catheters. Alternate catheters. So you'll see different sizes, and I wanted to give you images so you knew why they have these silly names. So the Pezzer mushroom shape, that one is specific for suprapubic surgeries. So they'll actually make an incision on the stomach in the suprapubic area and insert that directly into the bladder. So that's why that one looks so different. As you are studying, I want you to pay attention to when the Pezzer catheter is used and when this three-way channel catheter is used. The rest of the time, we're going to have a regular Foley catheter. So GU surgery is a time where you want to do a quick review over these different catheters so that you're familiar before you go into the room. But I put a picture of the whistle tip, Coude, multi-eyed, Robinson, and the Pezzer on there. So make sure you take a look at those so you have an idea what they look like. Okay, after that, please read through the rest of these different supplies that you could use during these types of surgery. Because again, it could be like cystoscopy set up like this, or it could be a big open belly case, you know, messing with the ureters and the bladder. It could be a lateral case where we're working on the kidney. So there's lots of different options here. Read through all of it. On page 810, go through all your different incisions. That worked out perfectly because I was talking about big incisions on the belly or the flank. So on your incisional options, read through all of them. Know the operative approaches that are listed here, and there's really nothing more to add to that. Example, look at your Gibson incision. So this is sometimes used for implantation of a donor kidney. So as you're reading through, make sure you have at least one example of what they're going to use it for. The flank incisions, look at your second paragraph. Your subcostal flank incisions are appropriate if the preoperative radiograph studies show the kidney to be lying low. So if something's not in the right position where the intended target would be, we're going to want more images to look at that. And we also might change our incision based on that too. So read through that second paragraph. Okay, so it starts talking about that subcostal flank incision. Look at your next sentence. It talks about the latissimus dorsi. Latissimus dorsi, big muscle on your back. So the latissimus dorsi, the external oblique, and the internal oblique muscles are all transected in this incision. So that's more than the usual. We're usually talking about just that rectus sheath. So I want you to pay attention to that section. And of course, everything in purple, so your Garatas fascia surrounding the kidney and any of the retroperitoneal contents. You should make sure to look through all of that. After that, stop at transcostal incisions. So these are made directly over the rib, and you do need to know that. They're made directly over the rib, selected for removal, and it's usually the 11th or the 12th rib. Okay. After that, you can see some images of that Gibson incision. I want you to flip over to page 812. So on page 812, it finishes up with the last lumbar incision, and then it goes to the Wilms tumor. So on this one, I want you to read through some of the anatomy and pathology so you can better understand it, and I added some pictures so you have an idea of what it really looks like. So for your anatomy, your adrenal glands, don't forget they also have an alternate name. So suprarenal glands or adrenal glands. Know that these are endocrine glands. Go through all of your bullet points and let's stop at, it starts with they are endocrine glands. They are endocrine glands with a cortex and a medulla. Hopefully you remember that part. It talks about the hormones that it's going to secrete. So steroid type hormones. So if you keep reading down, I want you to read about the medulla specifically. So the medulla secretes catecholamines, epinephrine and norepinephrine. Those are the two I want you to focus on. So catecholamines, if you forget that term, and epinephrine and norepinephrine are those two catecholamines I want you to learn and focus on. After that, know that your Wilms tumor can also be called a congenital nephroblastoma. So of course that'll be congenital. So most common pediatric tumor of the abdomen that affects the kidney. So know that this one originates in the kidney and eventually replaces most of the involved kidney. So this can cause hemorrhage and eventually necrosis of that kidney tissue. Read through and know your peak occurrences. So look at your last bullet point on page 812. Your last bullet point. The peak occurrence of this tumor is age 3 and rarely occurs after age 8. So 3 to 8 are most of your cases. So if you're working at a pediatric hospital, you might get to see one of these. It'll be a rarely seen case for sure. Okay, after that, you'll see I didn't go through that procedure because we're going to get at the kidney the same way. So you only need to hear that one time. So nephrectomy on page 816. Know that a nephrectomy is either total or subtotal. So it's not just removing the kidney. Make sure to pay attention to the details as you're reading. So total or subtotal. And then read where it says partial nephrectomy. So partial nephrectomy is performed to obtain a specimen for biopsy. So if it's cancer, we're going to be looking for a specimen for biopsy. So it gives you another example too. Remove small cancers, remove calculi that have caused damage to the surrounding tissue. So that's one other reason besides cancer. Okay, if you go to page 817, it actually talks specifically about a radical nephrectomy, and I want you to read through that part. So radical nephrectomy removes, of course, all of the kidney, but also the adrenal glands that sit on top of the kidneys, the pararenal fat, the upper part of the ureters, and the fascia that surrounds the kidneys. So that's why it's considered en bloc. It's getting everything. So sometimes lymph nodes can be removed, but radical nephrectomy is usually accomplished through an abdominal incision with the patient in the supine position. So we're going to be in supine, not lateral, to get that flank incision. Make sure you know that's a little bit different. Okay. Actually, after that section, let's flip to page 818. So open simple nephrectomy. On an open simple nephrectomy, it kind of goes through all of your anatomy. So I want you to read through all of your anatomy on page 818, and then I will continue from there. So I will get on and record one more lecture to continue with our open simple nephrectomy. So I will start here with this kidney anatomy so you can get familiar with that, and then we can move on to more surgeries. So I will be back with part 2.